Yes? Okay, great. Once again, my name is Dr. Bird. I'm from the Department of Urology here at the University of Florida. And today we're going to talk about comprehensive care for kidney stone patients. And as I thought about making this presentation, um, I thought that a good goal would be to really look at total stone care from the perspective of both urology and nephrology kind of put together. I think for a lot of us, either from the urology side or the nephrology side, we may hear about certain aspects of stone care, but we may not uh, see the whole picture sometimes. So I hope to focus on that today and have some time for questions at the end. The learning objectives are here, and essentially, what I hope you all can gain from this activity is to see what our state-of-the-art diagnostic tools are for identifying stones, and to understand both the surgical and the medical strategies for stone prevention, and then to see how this all comes together so that we can have a multidisciplinary strategy for prevention of kidney stones. And I think here at the University of Florida, through a great collaboration between the Department of Urology and the Division of Nephrology in the Department of Internal Medicine, we have really been able to create this. And we'll talk a little bit more about that as well. These are my disclosures. They do not have anything that pertains to this presentation. So let's just start with a little bit of history, right? Stones, maybe unlike some other medical diagnoses, has a long history. And when you look at ancient literature, you can see references to stone disease. And I chose these examples here because in one example, in the Sushrita Samhita, and I hope I say that correctly, you can see that in ancient India, there was concern or thought given to both the medical and the surgical treatment of stones, where different types of medical therapies were used to either treat or try to prevent stones. And if those failed, surgery was then used, right? So this identification of this multidisciplinary approach has long since been known. Where are we going to get the information to discuss what we're going to discuss today? The majority of it, right, is from the available literature. And in the field of urology, we now have the AUAs, the American Urological Association. We have guidelines for a variety of the disease entities we treat, and I'm sure that is the same for you as it is for most specialties now. And there'll also be some elements that come from the world of experts on stone disease and my experience as well. So I think it's important to understand that these are the AUA guidelines panels. And the reason why I show them to you is that you can see of course, the surgical panel really comes from the group of urologists that make up our world of urology. But you can see that, and for the medical portion of this, the panel is quite diverse in terms of there being urologists, a group of nephrologists, which I'm sure you all know well. Dr. Pennison is actually a PhD in nutrition, and Dr. White was involved for reasons of statistics and evaluation of statistical analysis. So I think you can see that a good multidisciplinary effort has been put into this. So here's the breakdown, what we're going to discuss. We'll start with diagnosis, talk a little about the surgery, and then metabolic evaluation and how we implement a stone prevention plan, and then a little bit about how we follow these patients through time. So when stones present, we all kind of know what happens when patients present with stones. They present with pain, and this is usually due to obstruction of the kidney to some degree. It can be mild or more severe. It's important to know is that the majority of stones that go into the ureter, they're small, and a lot of them are going to pass either painlessly or over a relatively short duration of time with not much pain. Hematuria is the most significant finding, and one of our larger concerns is that there may be infection associated with the stones. An important factor with stones is that there is a large differential diagnosis. And the reason why I bring this up is that it's very important to establish this proper diagnosis, because there is a group of patients that may need immediate, emergent, or urgent intervention. So this has to be very rapidly sorted out. And this leads a lot to why the imaging for stones has developed the way it has. Folks always ask about if I have a stone, what are the odds that it's going to pass? So this is a little age-old formula that's been used by urologists for some time. And essentially, this pertains to stones that have gone into the ureter. And you essentially can take this maximal cross-sectional diameter of the stone and subtract in millimeters and subtract that number from 10, and you will here you can see 10 minus 4 would be around 60% for a 4 millimeter stone, and if it was a 5 millimeter stone, it'd be 10 minus 5. And you see that as the stone grows larger, of course, the odds of spontaneous passage decrease a bit. Here is some information that's come out in the last few years. Actually, this is one of 2 studies that came from Canada, and it yields a lot of important information, because when patients come to the ER, one of the most important questions, of course, is how to identify those who do need some sort of immediate intervention. And stone size certainly has a lot to do with this. And you can see here, essentially what they plot out is that when you look at spontaneous passage, as stones grow in size by the millimeter, like we just showed with that more simple formula, that the odds that the stone will pass go down. And essentially, the larger the stone is, if you choose or elect to observe, the failure rate of that choice will increase. And this and another study, really what they show, really the take-home point from all this is that if stones are 7 or 8 millimeters and they're in the proximal ureter, right, just coming out of the kidney, still high up in the ureter, odds are pretty high that those stones are actually not going to pass. And a lot of those patients need intervention. And when groups have gone back and retrospectively looked at ER records, they can see that sure enough, patients with these size stones come back to the ER over and over again because spontaneous passage is not very likely for them. So this information definitely helps to identify patients and to expedite the care that they need. Let's talk a little bit about imaging for stones. Essentially, there's 4 main types of imaging that we think about for stones: plain images, ultrasound, MRI, much less so, and CT scans, right? And the important point here, right, is that we need high sensitivity to diagnose whether stones are truly present. For plain film imaging, of course, this is quite limited, as we all know. What plain film imaging is good for is that if a stone is known and you can see it on plain imaging, you certainly could follow it that way. Ultrasound and MRI have moderate sensitivity, but you can see here their sensitivities really only range in the 70s, and this is still too low to diagnose stones with a high degree of accuracy. And it really comes down to CT scans, which are by far the most accurate. And years ago, when these stone protocols CTs, or what we're called kind of like more rapid CTs, were obtained because they were just plain imaging without contrast, they became very popular, not only because they were quite sensitive and specific for diagnosis of stones, but they identified a lot of those other, or helped rule out a lot of those other differential diagnoses that I showed you a few slides ago. And so you can see that for many reasons, CT has become very ideal in this way. People often ask questions about the total amount of radiation exposure you get from CT scans. These stone scans, which essentially are plain scans of the abdomen and pelvis, are now low dose protocol scans. As long as patient's body mass index is not so high, you can use very low CT energy and very accurately diagnose stones. So these low dose CT scans are really where things are at should you need a definitive diagnosis for stones. CT scanners are of great value in that they yield a lot of other information as well. And really, the point to take from this slide is that you can see that the numbers given there, essentially, they're all some form of Hounsfield unit attenuation value. And you can see that these values range in different areas for different types of stones. And we can see calcium-based stones are, of course, quite dense. Uric acid stones, cysteine stones are lower in Hounsfield unit attenuation value uh, number. And struvite stones, which are infection stones, they're a little bit variable because they can have both metabolic elements of stone as well as infectious elements and certain degrees or percentages of protein and what we call matrix material, which makes those stones more variable. Here is kind of a spread chart of what you can see from both we see in low and high energy CT, or what people would call like a dual energy CT scan. And you can see the color codes there for the different types of stones. Problem is, as you can see, you can choose a different color there, like say the black for the calcium oxalate, or calcium oxalate mixed with different types of stone components, and you can see that they range over a wide number of values. And for that reason, unfortunately, this information is not specific enough to make CT scans themselves in the form they're in useful enough to get a diagnosis of the chemical composition of a stone. What types of things are being done about this? So here, I just want to show you an example of one of our projects we're doing at the current time, and we're doing this in conjunction with the School of Engineering, and this involves use of artificial intelligence to interrogate CT scans for more information. And essentially, what these pictures are showing you is that this is a type of artificial intelligence training that would be called supervised learning, right? So we would essentially show the software a number of CT scans, and you identify all these body structures, both the internal viscera, the bones, the intra-abdominal fat, the stones, and you would label all of these. We even chose some more specific labels for different stone types. And then once you feed a large repertoire of this information into AI type of software, the hope is that you can then apply this software and learn very specific information about stones. This is a project that is ongoing at this time, so hopefully in the future we'll have more to show. Let's just talk a little bit about removing stones and stone removal procedures. So here is a kind of a spread chart on what we do for stones. Essentially, the overwhelming majority of stones are going to be treated by these first three modalities, right, which we've all heard about in many different forms. Shockwave lithotripsy, retrograde ureteroscopy, which essentially means that we're passing a ureteroscope up through the urethra and bladder up to the kidney in reverse fashion. And then there's percutaneous procedures that are used. For smaller stones, both shockwave lithotripsy and the retrograde ureteroscopy are commonly used. Ureteroscopy has fallen more into fashion, if you will, because newer studies show that its success rates are higher. Percutaneous procedures are often needed when patients have very large stones or they have altered anatomy, which makes it not possible to traverse their lower tract. We're a tertiary care center, and we receive lots of patients with both complex anatomy and very large stones. So we perform a fair amount of these percutaneous procedures here. These days in the United States, it is very rare that you would need to perform any type of intra-abdominal operation to remove stones. Of course, this was all done a lot in the past. I actually got to train in a very interesting time period in urology. When I was urology resident, some open stone procedures were still done. and I essentially got to experience the larger evolution of urologic endoscopy to what it is today. So it's good to have seen all these things. But this is kind of the spread of what we do. Some particulars about them. When many people hear about shockwave lithotripsy, this essentially is what you hear about people laying inside of a water bath, right? And the idea is that shock waves are generated and sent into the body to break stones. Some key points to know about shockwave lithotripsy. To gain success with this procedure, you really have to select patients quite carefully. Stones cannot be too large. The larger stones get over 1 centimeter, success rates go down for sure. When stones are located in the lower portion of the kidney, the pieces will not pass, so it's not a great choice for those patients. The CT scanner can also be used to assess Hounsfield unit density. Once stones are over 900 or 950 Hounsfield unit attenuation value, they're known to break very poorly with most shockwave machines. And this is something that's good to use in preoperative assessment and patient counseling. The shock waves, obviously, if someone has larger body mass index, shockwave penetration decreases and success rates do as well. The procedure cannot be done with anticoagulants. Really, the larger concern with shock waves is that one, the stones may not break, and two, if they break, there's a lot of fragments, and these fragments still have to pass and could cause other types of issues. And some of the more common complications you see here, the most common, of course, is renal colic from trying to pass fragments. Gross hematuria can be seen. The fragments can cause obstruction. Less commonly, people can get hematomas or blood around the kidney, which is a little bit more concerning. And here, this is the kind of thing you can see where stones, if you look on the top picture there, you can see down towards the bottom on the right near the bladder, that's actually a stack of stones that originally was a stone in the kidney. Shock waves were given, and now you have what's called this Steinstrasse or Stone Street in German, which is where this was first seen because the lithotripters were first used there. The bottom picture shows you'll see kind of a brighter type of whitish gray around that lateral portion of the left kidney, and that is a perirenal hematoma, which you can also see from these shockwave procedures. So here I just put together a few studies that were done, and a lot of these studies were based from medicine and nephrology. And there's concern, of course, right, that if you are sending shock waves through the parenchyma of the kidney to break these stones, what are those shock waves doing to the kidney? In the early days of shockwave lithotripsy, a number of studies were done, and certainly a lot of microhemorrhage and scarring could be seen in some kidneys. And of course, people are concerned that the scarring of the kidney could result in new onset hypertension. There, of course, is some debate about this, but what these studies show is that this may very well be a concern. In the first study, shock waves compared to uteroscopy, where the shock waves were associated with more development of hypertension, where that newer scope I was telling you about was not. Another study showed no clear difference about shocking stones in different parts of the upper urinary tract. And then a third study showed this consistently increased incidence of hypertension on long-term follow-up. I think certainly these studies are all somewhat limited by methodology, but nonetheless, this concern is out there. And I can tell you that currently shockwave lithotripsy continues to decrease in popularity because of lower success rates and concerns like this. And that brings us to what's called this retrograde uteroscopy. And what you can see in this top picture, this is exactly how this is done, right? These scopes are now digital scopes. And as you can see below, the imaging is excellent. And then that lower picture on the left, that's a laser fiber, and that laser can be set to just either break the stone to dust or break it to pieces that you could then basket out with the basket there. As you can all well imagine, with increasing technology, these scopes have become quite good, and this form of stone treatment is now very popular. Um, as you know, these are the scopes that themselves. Really, the largest issue with these scopes is that they have to travel very far into the body. They can only be around 2.5 to 3 millimeters of maximal diameter, and as such, when they're used, they're relatively fragile, and they are prone to some degree of breakage, which of course can cause some cost issues with care. At the current time, more of these disposable flexible ureoscopes are coming out. And the largest reason they're coming out is because when larger stones are treated with these scopes, the reusable scopes can break, whereas the disposable scopes, you can use them for that one case and not worry about the scope breaking. Here's a study to kind of show you what I was showing you before, and you see 3 lines there, right? You can see that the blue line is shockwave lithotripsy, that its use and popularity is going down through time. The ureteroscope is going up, and then we know there's this subset of stone patients that have these very large stones, and they need percutaneous procedures, and this has remained the same through time. For percutaneous procedures, on top there, you see the kind of set that we use to do this procedure. And it's essentially, these patients can lay either prone or sometimes supine now as well. And in that lower right picture, you see that we have gotten needle access into the kidney. We put guide wires and guidelines down to the bladder. Then we dilate a track, and that tube there is a sheath, and then scopes will go through that sheath, and we can go around the kidney with both rigid and flexible scopes and take stones out. This procedure is very effective for larger stones or stones that cannot be treated by other modalities. You can see that its success rates are relatively high. Really, the largest complications of this procedure relate to hemorrhage. I think with more accurate percutaneous access, where we try to get needle access straight through the end of the calyx, and try not to come too obliquely onto the calyx so that we don't hit any types of renal arterial blood vessels. We have seen these transfusion rates go down substantially. I can tell you at the current time in our series here at the University of Florida, transfusion rates are around 1 to 2%. They're not very high. When I was training, I think those rates were still around 12 to 15%. They're actually pretty high. So a lot of progress has been made here. And this procedure, once again, very effective for larger stones or stones with very complex anatomy. What is new on this front? You may hear this term burst wave lithotripsy. We have seen this from a few centers now in the United States and in Europe. And essentially, this is the idea here, right, is that you would, in a paradigm somewhat similar to shock waves, you will use ultrasound probes where you can adjust the strength and the pulses, and you can use them to both move stones around, right? The idea there in that picture, right, is that you can push this stone or stone fragment out of the calyx to try to get it to pass, or you can change the settings such that you can break stones to pieces as well. And as you can see there, this is new. It does show some promise. Every year that goes by now, we see some further evolution of this modality, and it is expected to kind of reach patient care in the near future. Something good to keep an eye on. So now we're going to talk a little bit about metabolic evaluation, and I think the point I will make here is that I am a urologist, and I'm speaking to all of you as nephrologists. And really what I'm going to show you is how urologists, for the most part, look at metabolic stone disease. I think a lot of it is common to all of us, but I am sure you may all consider a variety of nuances when you think of things we can do when we evaluate patients for stone disease and then implement both diet and different types of medical therapy. What is important here, right? Stone disease is not only bad enough in that it decreases patients' quality of life and causes a lot of symptoms and potential complications and procedures requiring anesthesia, right, is that in addition to hypertension and diabetes, which you all know so well, um, there's a bunch of particular factors about stones that you see listed here, where these factors are associated with risk for CKD, and right, which is even all the more impetus to help these patients prevent further stone disease. um, who gets evaluated? As you can see here, there's once again in our AUA guidelines will give a list of different types of patients that we will evaluate, that we think should undergo a full metabolic evaluation for prevention of stone disease. And you can see that a lot of these things relate to family history, a lot of disease entities that relate to the GI tract, of course. You'll see different types of things. There are RTA type 1, hyperparathyroidism, other elements that are very familiar to you all, solitary kidneys, and of course, even any first-time stone former who's motivated, right? And I think the take-home message here, right, is that it is already known that urinary stone disease is so highly recurrent that it would not be surprising that once people are aware of this, that even having one stone, they would want to go ahead and do what they could to prevent more stones from occurring. And in this study that I list here on the bottom, what they showed was that when you compare the metabolic evaluations and 24-hour urine abnormalities, first-time stone formers and recurrent stone formers had the same amounts of these abnormalities seen. And you can see that the abnormalities they looked at, hypercalciuria, hyperoxaluria, low citrate, high uric acid, these are all factors very well known to be associated with stone disease and risk for stones. So at this point, really, if anyone is motivated, we would tell them that it's a very reasonable thing to do to be proactive, right, to prevent stones. I think we all know that a problem in our healthcare system for a long time is that we have been very reactive to a lot of things. And with stone disease, this is a great example where we should really be proactive, right? We already know stones can do all these bad things for people, and there are now things we can do to help them prevent them. Here is a list of items involved in evaluation from the AUA guidelines. And essentially, right, this boils down to the different conditions and risk factors that we talked about. Of course, in the history, gaining a good insight into, so I think this is very important, the one here marked in red, is gaining patients' insight into their perception of nutrition and food products, and just what different, what the nutritional value of foods is. And I think a lot of patients I speak to, and Dr. Rucci and I speak with this a lot, is that some patients, you have to help them identify the difference between fresh food products or relatively unprocessed food products versus more processed food products. And you can help educate people to control their own diet more. And this can actually make this, I think this is one of the factors that actually can make a large difference for the patients. Also, of course, we would then get a blood draw and do 24-hour urine collections, which are all recommended as well. What do we do? My view of all this is that when we are in the operating room, we always try to retrieve a piece of stone for analysis, as this is a component of the metabolic evaluation. We get a blood draw, BMP, check the calcium axis for PTH, vitamin D, and uric acid. And then we try to get 2 24-hour urines. I think this is variable, right? Dr. Rucci and I both know well that when you talk to these patients, you have to kind of see what they can practically do. As long as they can do one, that's good. We hope for 2 to try to get a better idea of what they are at their baseline state. And what I would add here, what is very important, I think it's best to make sure that all the stone material that you can remove is removed prior to this evaluation, so that there's no confounding factors in the urine that can help you with the evaluation. I just run a list here about kind of, why are we doing this? What are we looking for? And as we all know well, right, there is actually a whole bunch of pathophysiologic processes that lead to stone disease that you see here listed on the left. And you can see, of course, that patients, they can have any one or any combination of these factors. And this is actually what we're trying to identify. And you can see how common that you find a lot of these entities. So these are the types of things that we're looking for. In terms of stone type, we can go through the different elements of the metabolic evaluation to see what can be gained. In terms of stone type, calcium-based stones are the most common. And as I said, I think the serum testing for the calcium axis is very important. Uric acid stones, we know that for a lot of these patients, the primary driver is low urine pH, so we focus on that. Those cystine stones are rare. There is special 24-hour urine testing for these patients, which can assess for not only total cystine load, but the how much the urine is under or oversaturated with cystine. Struvite stones are infection-based stones, so we screen patients for urinary tract infection, but be mindful that these patients with infectious stones can have both infectious elements and metabolic elements leading to their stones. In terms of stone analysis, so at the current time, stones are actually sent out to geology types of labs where they examine minerals, right, with these types of different devices that you see here. So you send these stones out, it takes time. Obviously, there's cost. And of course, when we break these stones to pieces, we have to be able to get pieces of the stone to send. Sometimes if we send them very small fragments, they tell us that the fragments are not good enough for analysis because some of these devices may require some minimal amount or portion of these stones for analysis. Which leads us to something else that we're doing. And so because of these factors that I just told you about, we have another project here, which I'm very excited about, once again, with the College of Engineering. And what you see here is what we're trying to do is we're trying to assess the entire endoscopic environment where patients have stones. And as you can see, these are some pictures of stones seen through various types of endoscopes that we use to treat the stones. The last picture on the lower right is a picture of a stone fragment on a blue surgical towel after it's removed from the body, right? And the idea here, right, is that we once again train the AI software, right? We're feeding it all this information so it can learn about these stones. And you can see that we actually know what this chemical composition of these stones is, and you can see those labels. And this is an example of the label and then the AI reading and knowing what these different types of stones are. It all turns out to be much more complex than you might think because you essentially, the AI is kind of like a baby, right? You have to teach it everything. You have to show it, say, okay, this is the kidney tissue, this is the kidney stone, this is the laser glow, the glow from the laser. That's that little green dot there in purple on the bottom row. Or this is a guide wire, or this is a stent. So you have to teach it everything. And we know that we're going to need a large repertoire of these stones and endoscopic images to train the AI. But this is very exciting, and we think this is going to add to care tremendously in the future. Talking a little bit more about the evaluation. I just want to go through some questions that people or patients sometimes commonly ask, things that we look for. One of them is parathyroid hormone, and I know that all of you as nephrologists know a lot about parathyroid hormone, and essentially we do look for this in stone formers. I think people know they hear this old saying, bones and stones and groans, right? So you look for patients who have recurrent kidney stones, bone mineralization issues, bone joint pains, or other less specific findings and symptoms. You look for possible hyperparathyroidism. The majority of these patients do have elevated parathyroid hormone levels and serum calcium levels. Not all of them, which of course makes this diagnosis very tricky. I know sometimes when we're seeing these patients together in the clinic, and and I see these patients with Dr. Rucci, we see that some patients, it's not so simple when you look at the serum levels of a calcium parathyroid hormone. They get parathyroid scans, and sometimes these diagnoses can be not so easy to decipher or determine. Um, Many of you may know this is there's a clinic in Florida, the Norman Clinic over on the West Coast, and they over the years they've treated a tremendous amount of patients with who have hyperparathyroidism. They essentially do parathyroid surgery there in large numbers, and essentially they have compiled a lot of their findings into these tables that they make, and I think the tables that they have are very useful, and where they show where the range of hyperparathyroidism is, and you can also see that this overlaps the range of what people might consider, right, in quotes, normal blood calcium. Um, I think one thing that's very helpful with the EMR is that we can now very readily see patients' labs through time. And I've certainly become more suspicious of these patients who constantly have these serum calciums in the 10 range. And sure enough, some of these patients turn out to have hyperparathyroidism. I think another table they have that's quite useful, especially for me as a urologist. This helps me understand when I can see the blood parathyroid hormone levels as well as the blood calcium levels, and it helps me kind of figure out where people are on this. And as you can see, for the diagnosis of primary hyperparathyroidism, um, even though the 50 and 80% ranges are a little bit more confined, there's actually a wide range of lab values where patients can be diagnosed with hyperparathyroidism. Um, some quick information about vitamin D. I know this slide looks very busy, and we all know that there are many studies that deal with vitamin D, and there's a lot of controversy about it. And I think what everything boils down to is that we all know that there's a whole bunch of statistical studies that are done that show association of a lot of medical disease entities with vitamin D levels, and that vitamin D may help ameliorate some of these conditions. Uh, and then essentially from this point, a large amount of studies have been done, and essentially now we're talking about systematic reviews and meta-analysis, where it's one meta-analysis versus another meta-analysis, right? So there's a lot of data, and but there does appear to be some information that, to some degree, that vitamin D levels, and if they're higher, they certainly could be associated with some increased risk for stone disease. I think, when you read through these studies, there, of course, there's a lot of limitations in methodology in a lot of them, making a lot of them very hard to compare. So you really have to parse through them carefully to see, how good their methodological quality is and what to make of their results. Some common studies that we look at as stone urologists, we know that vitamin D repletion is now very common, and we are interested in whether these repletion efforts lead to increased urine calcium in stone disease. One randomized controlled trial done for this showed that this did not appear to be the case for stones, but the higher dosing may result in better repletion for patients. I think the question then becomes, once patients are repleted, are they then put on a maintenance dose, or are they left at one of these higher doses? Sometimes I see stone patients and they appear to remain at these higher doses, and I'm not sure if that's the best thing for them. We also look at these health professional studies, and the Nurses Health Study 1 and 2. They have a lot of information. I think the quality of the data is somewhat limited, but the suggestion there is that perhaps at higher doses of vitamin D, there is some increased stone risk. But once again, I think the quality of the data there is not great to conclude anything more than that. 24-hour urine collections, we were talking about this before. Many people ask about what the value of these 24-hour urine collections are. And certainly as urologists and nephrologists interested in preventing stone disease, we use them. But it's interesting to see that when you assess this at a larger level, you can see that many of these patients don't get 24-hour urines, or if they get one, they don't get any follow-up 24-hour urines. And the bottom here, with I list some reasons why this may be the case. Right, the case may be about how people feel about trying to interpret the 24-hour urines, assessing who would need a repeat collection. Really, I think a repeat collection is best to see if you made an intervention, is that intervention resulted in changes to help hopefully lower the patient's stone risk. And some people question as well how accurate some of these cutoff values are for what may be normal and abnormal levels. And what's been recommended is that more trials and studies are certainly needed to try to see what type of comparative effectiveness does exist for these 24-hour urines. Clearly, at the current time, it's one of the more useful items we have. My kind of last thoughts on that was I think these tests certainly are quite useful. I think in reality, because they just assess a very small period of time, patients would be better served with some type of more dynamic test, right, where you would know their urine calcium more than just this 1 or 2 times. You might know what it is once or twice a week or a few times a month, right, to try to give the patient a larger picture of how much risk they have or whether their efforts are working. So I think that's where things are at with 24-hour urines. And I think in the future, we are going to see devices where people will give a more rapid and more frequent assessment of these results. A little bit about the prevention plan for stones. Once again, from the AUA guidelines, we all know a lot about fluids and diet. Certainly, high-quality studies show about the amount of fluids that are needed to help decrease stone risk. And there's a lot of information as well on limiting different types of non-dairy animal protein and oxalate-rich foods for groups of these stone formers. What's important to know is that a lot of this data is not supported by much evidence. A lot of these items are expert opinion, but that is where they are at, and they certainly form part of the foundation of what we do, because there is a fair amount of, if you will, circumstantial or secondary evidence that this indeed is the case. Some other more specific items from the guidelines as well for different types of stones. We all know that avoiding large amounts of vitamin C is important to keep oxalate levels down. The point to make about citrate here, right, is that we all know that citrate therapy can be used to decrease stone risk. It's important. Really, the better term for this is total alkali load, right? Citrate in its acid form probably may not make much of a difference unless it's some type of direct inhibition of crystallization. In terms of fluid intake, right, as simple as this sounds, it's very important. And for anyone who takes care of a lot of stone patients, they know that a lot of these patients continuously do not consume enough fluids. And what you'll see now is that there's a whole bunch of apps and devices, right? They're all used to be a type of biofeedback for the patient to try to motivate them to, or remind them to consume enough fluid every day. So sometimes you see people walking around with certain jugs and containers, and really the most effective value there is that it's a visual cue for them to remember to consume more fluids. We all know about some of these dietary items. We all know that a lot of these processed food items can have very large amounts of sodium in them, and you can calculate this sodium intake from 24-hour urine values as well. What I would say about fluid and diet recommendations, and we talk about this at our stone meetings a lot, is that we all know that stone disease is very heterogeneous. There's a lot of things we can tell the patient, but I think it's very important when you speak to the patient to identify or to understand how they perceive stones, and then try to choose some high priority items for them to work on to help them avoid getting stones, right? For instance, right, if a patient doesn't have high urine oxalate, maybe just telling them to not consume, to focus on, you know, not consuming dark green leafy vegetables or something like that may not be the best approach, right? They may be better served by focusing on hydration, lowering their sodium, and things like that, right? So it's very patient specific. Um, as we all know, and you all know well, that for a lot of the medical therapies that you give, really patients they need to work at the dietary and disease control level to help control more systemic issues they have, because this is what's going to help them prevent stones. Just jumping straight to medical therapy is not going to work. These prerequisites have to be in place first. Um, treatments you see here. Here's a list of a whole bunch of different types of interventions we can use for different types of pathophysiologies that we see. And you can see that there are studies that clearly show that for these interventions, when they're given, you can decrease risk and stone events. You all know well about thiazide diuretics and their effects and their use, especially for calcium stone formers, to lower risk for stone for new stones and overall risk for stones. They do come with certain types of complications, and of course, these patients need to be regularly monitored with labs. Um, I, uh, I know that hydrochlorothiazide and chlorothalidone, these both can commonly use, and we use them a lot. Um, but there may be certain patient selection differences that come up at times. Indapamide is used as well. I know from working with Dr. Rucci that this has been used more in recent times. I can tell that a lot of patients are quite satisfied with it, and I know that it's patient satisfaction with it is pretty high. And it's my understanding that it can be safer for patients with certain other types of metabolic issues as well. Um, potassium citrate. We all know that potassium citrate is commonly used for stone prevention. The most important points to know about potassium citrate are that you have to give enough of it, and you have to give it as an alkali load for it to make a difference to patients. Right. The most common thing you hear is that patients will tell you, "Oh, I get my potassium citrate online," and then you have to show them that the product may have like 2 milliequivalents of potassium citrate, and so they're not really getting much citrate at all. Here are some other recommendations from the AUA about things that we do for pharmacologic therapies for stones, specific for uric acid stone formers, cystine stones. Certainly, management of pH is very important in stone prevention for these patients. For infectious stones, we used to give pseudohydroxamic acid in the past. It's not greatly tolerated, and our surgical therapies are much better today, so it's not used very much at all. Potassium citrate has known cost issues. I'm sure you all know who that is in the picture there, Dr. Coe. And a lot of patients would tell you about all the difficulties they have getting potassium citrate, especially from different pharmacy tiers with their insurance. In recent years, because of this, a number of studies then came out examining a whole variety of over-the-counter products and how much citrate load they have. The first one of these showed the effectiveness of Crystal Light, or the amount of alkali that it had. And then in recent years, I know these are some large tables, and really the only thing I want you to gain from these tables is that there's some of these new preparations like Moonstone and Litholite, these KSP tabs, where now patients can get citrate, with known amounts of alkali load in them, and they can get it much more reliably and at a much lower price. And I think this is helping patients a lot. In summary, right, we all know that what prevention of stone disease is all about is a combination: fluids, diet, pharmacologic therapies. And really what matters, right, is the overall plan and what you're doing for patients' total health, right? It really is a patient-specific type of care plan. In surveillance, really the most important thing is, right, is that you need to monitor labs for renal function, And if patients are taking medical therapy for stones, you may need to watch certain items like their potassium or liver function tests or things of that nature. In urology, we follow patients with ultrasound, usually at 6 month intervals until 2 years, and then that's out to a year. And then if they remain stone free, up to 2 years. Um, what do I see in the future? I think what really is going to be one of the most important things is having a multidisciplinary approach, which combines all the elements that I'm showing you here. And I think that, like I said before, you need to really identify which recommendations are going to mean the most for individual patients. Um, Dr. Rucci and I, we have a multidisciplinary stone prevention clinic. We've had it for years. I think we have a great partnership. I very much enjoy my time working with the whole department of a whole division of nephrology in this respect. Um, we had a recent publication as well on, and this publication involved 10-year results for patients and with stones in terms of stone prevention. And I think the strengths of what we show is that really, right, it shows you what's important in this 10-year follow-up is that it's a lifelong type of issue for the patients. Stone recurrence needs to be assessed over a longer duration of time. I think a lot of studies have too short of a follow-up period to really assess stone risk. And I think one of the great values of this study is that it's about total care, right? It's about fluids and diet and supplements and medications and how they all play a role in stone prevention. We have a lot of patients in our clinic. I think their satisfaction rates are very high. And Dr. Rich and I plan to do more to kind of look at what we can do to help this patient group. I want to thank you all very much for your time. I know that you have a busy schedule, but I'm happy to answer any questions that anyone has.